Welcome to ATCM, the Emergency Medicine channel.
Start.
14-year-old female patient came to ER with alleged history of deliberate self-harm. She had intake of 15 tablets of Risperidone 1 mg and came to ER after 16 hours with complaint of abdominal discomfort and multiple episodes of vomiting.
Okay.
For initial 10-second assessment, patient was conscious and oriented and alert. Primary survey, airway was patent. There is no pooling of secretions or gurgling. Breathing part, respiratory rate is 20 per minute. Saturation is 98% of room air and bilateral equal air entry. Circulation part, heart rate is 110 per minute and BP is 90-60 millimeter mercury. Disability part, GCS is E4, V5, M6. People's bilateral equally react to light and there is no evidence of any rigidity and moving all four limbs. Exposure part, GRBS is 86 per million deciliter, temperature was normal.
Okay.
Coming to primary to the adjoint to primary survey, we taken an ECG. ECG was normal sinus rhythm with heart rate is 91, QRS is 84 millisecond and QTC is 478. And we taken a VBG. VBG was there is no acid-based abnormalities. Coming to the secondary survey, 14-year-old female patient, she is a known case of psychiatric disorder on risperidone, fluoxetine 20 mg, clonazepam 0.25 mg. Due to some internal family issues, patient had taken 15 tablets of risperidone 1 mg. Followed by 24 hours, patient developed multiple episodes of vomiting and abdominal discomfort and patient came to our here. There is no history of any altered sensorium, fever, rigidity, seizures.
Okay. So let's start seeing the drug risperidone. Okay. So risperidone, what is the class of drug?
Second generation antipsychotic, atypical.
We can call it as atypical antipsychotics. So how does the atypical antipsychotic work? So that will give you the answer. What will be the manifestation that we are expecting from a patient who has taken risperidone overdose?
It has main action is dopaminergic antagonist and it has multiple action like antimuscarinic action, alpha-1 adrenergic antagonistic action and
5-HT2?
Serotonin anti-serotonin action and histamine action also.
Okay.
Main action is antagonist action of D2 receptor in mesocortical area, mesolimbic area.
So that is the main reason. There are two major manifestations. What we need to keep in your mind is extrapyramidal symptoms and second one is arrhythmia with hypotension. So cardiac instability and extrapyramidal symptoms. These are the two things that we need to keep in our mind. So now let's see the pharmacokinetics. Any drug that we are discussing, we should know what is the pharmacokinetics. So then only we should anticipate the management. So what is the time for absorption and maximum peak level happens when?
It is a rapid oral absorption is there and very good first pass metabolism. It is peak within 6 hours. It will take into.
Just remember, it's just like paracetamol. Rapidly absorbed by GI tract, 4 to 6 hours will be the maximum peak concentration. Paracetamol also 4 hours, so that is the peak concentration that you are able to get.
Metabolized by liver by cytochrome 450 enzyme.
Okay, cytochrome P450. Okay, fine. The next question, what is the toxic dose for a child?
Maximum dose is 16 mg is the maximum dose.
See, it is a very potent toxic drug, risperidone. But what is the toxic dose? You have to say till like below this mg, above this mg. You can remember one. First thing, if for a child less than 12 years of age, more than 1 mg injection itself is a significant dose. Next one, for more than child above 12 years of age, more than 5 mg of consumption is significant. Or else, more than 5 times the regular dose. Whatever be the child that has been taking, basically they will take this for schizophrenia. So that's the main reason they are taking an atypical antipsychotic. Whether the consumption dose from whatever she was taking before, from that 5 times she has consumed, that is a significant toxic dose. And what is the other potential risk? What is the other group of patients that we wanted to know? Non-accidental injuries. Similarly, somebody can try to poison the child. So then also it is very significant. So that time we have to take it as a toxic ingestion. So remember, less than 1 mg, so more than 1 mg for 12, less than 12 years of age, more than 5 mg, and more than 5 times the dose the child was already been prescribed for. So this is the main important thing. Now the patient has come to the emergency room. First step, airway, breathing, circulation. GI symptoms not very common. Actually, when frankly speaking, for any toxicity, you can have some GI upset, but it's usually rapidly absorbed and eliminated from the body. Maybe by 6 to 12 hours, the manifestation usually will get over. But remember that once they are coming to the emergency room, what will be your action plan? Airway, breathing, circulation. What are the challenges that you can have?
A young patient, so
Airway.
There is pooling of because of hypersalivation, antimuscarinic action. It is antimuscarinic action, so it is dry mucous membrane. Some antipsychotics causes hypersalivation, pooling of secretion. So we will secure the airway. We will intubate the patient for securing the airway. If the patient is severe drowsy, is not able to secure the airway.
Okay, fine. So usually risperidone won't create these issues. Airway problem we don't see much unless and until she had a seizure and her airway is under compromise. But usually it will not be a major problem. Coming to the circulation part.
It has a alpha-1 adrenergic antagonistic action. So patient will go into orthostatic hypertension and severe hypertension. So we will resuscitate the patient with IV fluids. In children, we can give 20 to 40 ml per kg fluids we can give. In adult with cardiac instabilities, there we can give up to 1 to 2 liter fluids we can give.
What is the most important thing that you need to keep in your mind? Avoid dopamine and adrenaline.
No.
Avoid dopamine and adrenaline. That's the most important. We wanted to start a vasopressor agent. Noradrenaline is the drug of choice. Why? Because both these drugs have got significant beta-1 effect. So there can potentially worsen the arrhythmia. Already the risk of arrhythmia is high in this group of patients, so that can happen. So the next thing you said, you have to take an ECG. So what all things you want to look in an ECG?
ECG, we want to rule out any prolongation of QRS. Normally take 2 to 3 milliseconds. So it is around less than 120 millisecond. If it is more than 120 millisecond, we can give sodium bicarbonate. 1 to 2 milliequivalent IV bolus we can give. Then next challenge is there is leads to prolongation of QTC. So if it is QTC, normally female group it is up to 460 millisecond. If the QTC is more than 500 millisecond, we can give magnesium sulfate 2 gram IV over 10 minutes. There is a chance of developing torsades deep pointers. And patient in torsades deep pointers, we can give magnesium sulfate 2 gram IV bolus. Dose we can followed by 2 to 4 mg per minute infusion we can start.
Okay. Again, this patient, one concern would be the patient had multiple episodes of vomiting. So that can worsen hypokalemia. So hypokalemia again can worsen the chance of arrhythmia. So we have to correct that also. So that we need to keep that in your mind. So remember, in circulation, the challenge will be to manage the hypotension. Dopamine and adrenaline should be avoided. Preferably start on noradrenaline. The next thing, as you rightly said, is regarding the torsades pointers and QTC prolongation. That is most commonly any antipsychotics. And another thing is that always keep in your mind regarding co-ingestion. He has taken fluoxetine also is a regular medication. So you need to remember that all these drugs will have this QTC prolongation. Fluoxetine can also increase the QTC. So keep that thing also in your mind. Okay. Now coming to the next, how will you manage the seizure?
Seizure drug of choice is benzodiazepine, lorazepam or diazepam is the drug of choice, and avoid phenytoin, which again in some antipsychotics because sodium channel blocker action is there, so prolonging of the action. And in patient with like it's extra pyramidal side effects like acute dystonia, rigidity will be there. For that we can give benztropine or diphenhydramine we can give.
Benztropine or diphenhydramine. So remember, seizure management, 3 drugs that you can remember, you can give safely is one is your lorazepam, diazepam and propofol. Is the next agent will be propofol. Don't think about phenytoin or fosphenytoin. So these 2 drugs are sodium channel blockade agents. So they can further worsen the arrhythmia. So that holds true for any antipsychotics administration. If you find seizure, avoid giving a drug toxicity, avoid giving phenytoin and fosphenytoin, especially with antipsychotic toxicity and SSRI, all those toxicity, you have to keep that in your mind. Then regarding your seizure management, we have discussed. Then benztropine or diphenhydramine. Diphenhydramine, how is this available? Diphenhydramine, how is it is available?
25 to 50 mg IV we can give.
Is this available as IV? It is only available as a syrup. In our country, we only have a syrup. The only thing what we can give is diphenhydramine.
To 50 mg IV is outside. Now available syrup is available here. Sir. Another one is benzatropine. We can give 1 to 2 mg IV. We can give, followed by we can give 2 mg oral BD for 3 to 5 days.
Okay. So now, who all needs admission?
Initially, if patient came with his complaints, we can observe the patient for 6 hours. If the initial ECG showing is normal, and we can repeat the ECG after 6 hours and vitally stable, there is no other extrapyramidal side effects and alpha-adrenergic side effects, dopamine side, nothing is there, we can dispose the patient. If the patient
Discharge the patient.
Discharge the patient.
Discharge the patient. We missed regarding gastric lavage. Whether we can give gastric lavage or not.
Yes, within 2 hours we can give gastric, but rapidly.
It is rapidly absorbing. So there is mainly this rapidly absorbing drug. When they are coming immediately after consumption, we can try for gastric lavage. So otherwise there is no role for gastric lavage. Activated charcoal, again no role. Activated charcoal, it's again rapidly absorbing. So there is no point when they come in to give activated charcoal. So gastric lavage is out. Not out, I am saying. They are coming very early, we can try. But unless and until they are very rarely they used to come. They take it and they will come after maybe 3 to 4 hours. So key thing regarding risperidone, that whether they can develop malignant hypothermia or neuroleptic malignant syndrome.
Chances are less, but the side effect is neuroleptic malignant syndrome. If it is patient person with neuroleptic malignant syndrome, we can tetrad is there. That is patient person with fever, altered mental status, then sympathetic lability and rigidity,
muscle rigidity. That's the most important thing that you need to keep in your mind.
Like lead pipe like rigidity.
So how will you treat neuroleptic malignant syndrome?
Neuroleptic malignant syndrome, for rigidity we can start with benzodiazepines and sedate the patient. For hypothermia we can give, hydrate the patient, and external cooling we can give, and other drugs we can start with dandrolin
sodium
and cyproheptadine. We can start.
Dandrolin sodium is not available again. It is cyproheptadine is only. Again, it is available as a syrup. So cyproheptadine, where we will use cyproheptadine? Where we commonly use cyproheptadine? Appetizer. That is the only role for cyproheptadine, appetizer, to improve the appetite. So regarding one thing, extrapyramidal symptom. What will be the extrapyramidal symptom that you will be able to see?
One is acute dystonia. Acute dystonia, it is an uncoordinated, involuntary, hyperkinetic movements seen in face, tongue, lips, that area.
Okay. So very important. Sometimes people who have not seen this acute dystonia, they will think it as a seizure. Very rarely, but they will treat and it will not subside. And then what is the difference between dystonia and seizure? Sensorium. Sensorium will be preserved in its acute dystonia and all those things. But in seizure, sensorium will be definitely affected. So that is one thing that you can tell. Can you tell me few drugs that can cause this extrapyramidal symptom in our common practice?
Clonazepam.
Common practice, I don't prescribe clonazepam very often. Most common drug.
Metoclopramide.
Metoclopramide is the one drug that we very commonly used to give it for vomiting, and they will come back with extrapyramidal symptom.
Haloperidone, Finagran.
Haloperidol and Finagran, when you are giving it in a combination, it will not happen. Rarely. Ondansetron, rare, but most common is metoclopramide. What we have seen is metoclopramide. And the thing is that once you give, what you have to give? When you see an dystonic reaction, we can give Finagran also to this group of patients, that they will have significant improvement and the patient will reward you and go out of the emergency room. So acute dystonia, you have to be very good at it, because when you are differentiating it with the seizure, you just give one shot of a drug, everything, the facial, because the facial features, once you see that, it is totally difficult for the patient, because painful, all this movement, and the patient is willing to stop, but she is unable to do that. So those sort of things you will be able to see, and once you just give one drug and everything is settled. the patient will be very much happy. So acute dystonia, Risperidone, atypical antiseptic, neuroleptic malignant symptom, malignant hypothermia, admission. Rarely they can go into this fatal arrhythmias, but fatal arrhythmia management we have already discussed. Arrhythmia management is with bicarbonate. That is what we need to keep in your mind. Arrhythmia management is with bicarbonate therapy. When you have a patient with magnesium sulfate and bicarbonate is the treatment option, not our regular ACLS. When you go for regular ACLS with amiodarone and all, it will create more problem and it will be more harmful to the patient. Remember, toxicological cases, whenever you see arrhythmia, the antidote there you have to use is bicarbonate and maybe magnesium sulfate, depending upon the scenario. Risperidone, that's it. The child would have absolutely fine got discharged. She has come after 16 hours. She don't have any cardiovascular or any dystonia and all. She can be discharged. So she may be kept under observation because of the dehydration part and vomiting. And next day she could have got discharged. And always remember regarding medico-legal responsibilities. So we have discussed in the last discussion regarding the medico-legal part. Anything else that you want to add? Okay, fine. Thank you.